Today I'm honored to present John Chappel, MA, Registered Physical Therapist, Director of SYNACTIVE Pediatrics, URSA, Educational Institute for Manual Therapy, Sacramento, California. John's a neonatal physical therapist who's worked with infants and their families for over 37 years. He received both a Bachelor's and Master's of Arts degree from New York University, graduating in 1985 with a Master's in Kinesiology. John is a sought-after, currently serves as a Director of SYNACTIVE Pediatrics Curriculum and Senior Faculty at the URSA Educational Institute in Sacramento, California. He also is NICU certified. His presentation will be Understanding and Utilizing SYNACTIVE Ergonomics and Their Role in Successful Feeding Outcomes, Establishing the Early Foundations. Thank you very much, and may I present John.
Hello, everyone. Can you hear me? I hope so. Good afternoon, everybody. We're going to get started. We have a lot of material to cover, so we'll begin. I won't read the objectives because I believe most of you have those. We'll cover all of them today, I hope. The first thing we have to realize is we work in newborn intensive care units, and really no field of medicine and no field of nursing has changed the lives and the mortality rates of their patients as fast and to a greater depth as neonatology and neonatal nursing, along with perinatology, obstetrics, and labor and delivery nurses. But basically, it's about mortality. And yet what we do as therapists and what we do as developmental interventionists, not only what we do will impact mortality rates, but we are interested in the morbidities, the enormous morbidities that our patients have and are left with for the rest of their lives. So today what we're going to do is we're going to take a look at kind of the landscape of what are the foundations for feeding. And I think at the end of this we'll begin to look at a different viewpoint and different things we need to do as therapists, nurses, doctors, and even family members to change the outcomes. In the fields of observation, chance favors the prepared mind. And what we'd like to do today is prepare your mind for looking at different things when you see an infant, when you talk about babies, and indeed what you do in your clinical practice. We're talking about NICU Ergonomics, which as far as I can say, this is the first lecture I've ever seen with it in it. And I've described it as the scientific discipline devoted to the study, analysis, and application of biomechanical factors affecting functional synactive acquisitions. An understanding of the role of biotensegrity in supportive care to reduce stress, discomfort, and fatigue in the sick infant through the efficient energy use in the maternal infant caregiver NICU. Environmental dynamic. And if we're going to talk about infants and the environmental dynamic and development, we can't begin or have to end with Dr. Heidi-Lisa Alls. I find that most practitioners who are feeding infants really pay more of a lip service to synactive theory than they do have a great working knowledge of it, when in essence we'll show today that the problems you're seeing with your infants have begun before birth and indeed at birth. And there are things we can be doing as speech therapists, PTs, OTs, whomever is listening today, right from the first day looking at infants and affecting outcome. So how does the infant handle the experience of the world around it, especially a sick infant? They do so by continuous interorganism subsystem interaction while continuously interacting with their environment. And this is what Dr. Alls is famous, as I call it, the developmental tornado. You can see that it begins at conception, and each week that goes by, we see more and more fetal competencies. At the core is autonomic functioning. This is what we have to pay attention to, facilitating the best autonomic subsystem stability to allow the motor system to reinforce it and the motor sensory system of feeding. Making sure babies have an adequate state control and abilities, autonomic motor abilities to support state control so that they can be attentional and interactive during their feedings, as Dr. Sue Thorey says, awake, alert, participating. So question, which of the following physiological symptoms does respiration not affect in the synactive functions? This is a trick question, everybody. Cerebral spinal fluid system, well, it certainly does with intracranial pressure and cerebral blood flow, as does positioning and posture. Lymphatic system flow and function, Look at how much trouble our babies have, not only getting fluid out of their lungs, but fluid out of their bodies. And this is an immunological function as well. Cardiac output and input, systole and diastole, absolutely. Oral motor, the aerodigestive system. Well, respiration is the timing, function, and flow of all feeding. And that's what our focus is going to be today. We really need to, as a group of people who are doing developmental interventions and looking to facilitate the best outcome feeding, we must become experts on the respiratory abilities of the infant. Not just the birth, suck, and swallow, but what forms the core of good respiration. Subdiaphragmatic and GI motility. This is obviously something we'll talk about today. Pelvic diaphragm and floor, working on all lower transiting of feedstock and elimination. And the bottom line is, once a baby isn't respiring better, autonomic nervous system integration is changed, vagal functions are changed, and the hypothalamic pituitary axis, the limbic hypothalamic pituitary axis, is grossly affected. And in fact, if those of you who heard me speak last time at Developmental Interventions in neonatal care, we looked at how the HPA axis actually helps the prefrontal and frontal cortex tune into development. So we have an infant here. Many times, if you're a feeding therapist or someone, there are so many things we have to be doing at this juncture, right here, right now, today, or I should say things that we shouldn't be doing to build a better respiratory system and respiratory abilities. And we'll see this baby on and off, take a look at what's going on. And if we look at this infant, we know that their cerebral spinal fluid system is being impacted. The passive extension in their neck with the nasal intubation is creating blood flow pressure changes, venous problems here. It's disorganizing the entire pharynx and super, and hyoid functions of the oral motor system. It's changing the way the thoracic cage works and even the diaphragm works. And we're going to concentrate on this area first today, as well as positioning upper extremities in different postures, which again limit or facilitate functional use of the thoracic cage. So once in full gravity, immediately after birth, the NICU infant carries with them a biotensegrity, a load throughout its entire body and its systems that will be affected with all systems from molecular level to global synactive functions. Biotensegrity is the application of tensegrity principles to all detectable scales in the infant's body and within their immediate environment. It encompasses everything from first-order sensory neuron functions, musculoskeletal deformations, altered aerodigestive functions, cellular functions, protein synthesis, and epigenetic destinies. And when we talk about putting an infant in the best possible place to succeed, we are literally talking about their epigenetic destinies. And many things we do or don't do from that 23rd week on almost dooms the baby to a horrible feeding experience. So we need to clean up our act, and we need to look at what we can be doing early so the poor feeding therapists and mothers and nurses and doctors don't have to wonder if this baby's going to eat well. We do it by setting up synactive integrities. Developmental caregiving has succeeded when an infant can be positioned, held, or moved in such a way that no endogenous physiologic or behavioral stressors are being delivered from the infant's body back to itself. And you'll see that this is a matter of good positioning, adequate positioning. I don't mean holding babies in a position. I mean finding positions where they are most comfortable physiologically, working the best synactively, and have an ability to move and become a moving being. It allows the adequate adaptation of synactive systems and states to the exogenous, the outside environment, and caregiving influences we create. Now, I'd like everyone listening right now, and this is a little mindfulness exercise I do, if you can, just close your eyes and stop and think. There's an infant that you've had in your recent experiences that brought you to this webinar today, and we will show you a position. A baby who, when they left the nursery, really didn't look or behave or physiologically function or bond with its mother or feed well when it left. Okay, now you can open your eyes. We create the problems that babies leave with, period. And that's the biggest thing when we talk about respirations. We actually need to up our game and see what's going on. So the body of the infant becomes a primary handle to change physiology and behavior, a handle. Developmental caregiving and its interventions must begin to account for all the stabilizing elements of tension and compression existing at all levels in the infant's body, specifically in the realm of normalizing respiratory function. Respiratory function is a set of tensions and compressions from the alveolar level all the way out to the neural controllers. Understanding this biotensegrity is the key to all effective pulmonary habilitation and rehabilitation for the human infant. And all of these systems, as you know, you've heard me speak before, this is page 156 in Netter, all of these systems, when they are under duress, an intubation, a heart surgery, a stomach that's being pushed to its outer limits every day by a quantity-based feeding as opposed to a quality readiness-based feeding, organ systems below that are problematic, colon, being able to eliminate, pelvic floor, all of these things feed back in and ratchet up this entire sympathetic system and feed back into brain and frontal cortex. All right, I'm sure usually when we talk to a group, everyone goes, ooh. So let's just use this baby for a second and take a look. Who would like in the audience to feed this baby today? You know, but yet you're called upon by a medical and nursing staff sometimes that says to you at whatever, 34, 36 weeks and says, oh, this baby's ready to eat. What can you do for it? And what I would say is, well, you guys missed the boat. You should have been preparing this baby for this day. So let's look. If I'm a physician, I'm wondering about what's happened intracranially. Did I spare this brain? How are these babies' eyes? We chop this baby up into our professional realms of expertise. We become professional bigots when we look at this baby. I can already tell you there are a number of people looking at this. How is the nasal intubation? Is the septum there? Nurses are looking like skin looks really good. It's great. Baby looks pretty good. Mouth is good. You know, seems okay. Speech therapists, OTs, PTs looking at this. PTs especially are looking at this, aren't we? Because that's what we tend to do. OTs are looking up at extremities. But really, who's looking at this? Who's really taking into account all of this part of the infant and how it has to work? So we're going to talk about that today. We are is the answer. So yes, I have a lot of questions, just like this poor infant did. And if you look at this baby, you can see already cranial malformations, cranial asymmetries, tone asymmetries around the face and jaw from writing problems. He's going to be a difficult baby to feed as well, but we can help put you together, kid. So no one completely recovers from being born, and certainly not our babies. We know. It's a joke, but we set the epigenetics of these infants up for either success or failure from the first moment they're in our nursery. So let's kick back for a minute and kind of think, take a breath. We're going to look at the respiratory system in a way that I look at it and kind of bring everybody together to kind of look at this respiratory system as a functional thing. So there are 4 functional units in the respiratory system. This is from Mortola's work, and it still is together enough. Each area of this has people who are experts, but we need to be experts on all of these. So if we look at who are the experts in gas exchange and alveoli, well, it's going to be the physicians, the respiratory therapists, the nurses who are giving medication, who are doing things to change respirators and change function. They are the experts in that. How about airways? Airways also, physicians, respiratory therapists, nurses, nurse practitioners, looking at bronchioles and bronchial tree. Those are their expertise. The respiratory pump, which is all of the musculoskeletal components of respiration. I'm pausing here because it's not this group and it's not this group. It should be therapists and people into developmental intervention, because unless you know as much as you can know about this system and how it's individually being assisted or inhibited in your patient, you will not have good feeding. You will not have good outcomes, and your patient may actually die. Lastly is the neurological drivers, and this is where we tend to over-focus as feeding therapists, not just of the neurological drivers, of the obligatory drivers in the oral digestive area and pharyngeal arch structures, but what are the neurological drivers into this chest and chest wall for this infant? And we need to pay attention to that as well. The rib cage is a component of the respiratory system. Well, of course we all know that. It is a structural and functional unit. Oh. And any change in its structure changes function. Any change in its structures changes function. Any change in sensory input changes motor output, and vice versa. Would you agree? I hope so. Thoracic musculature begins as sheets of muscles in the fetus. They are not totally based on what they should be, but on how the fetus moves in utero, or how the fetus moves extrauterine. And you will see that stuck baby again. What fetal capabilities do you have at 24 weeks? Good question. The fetus and baby build what is going on to be, the fetus builds what it is going to be by its movement repertoire. The thoracic cage is a place that adapts readily to environmental and musculoskeletal movement parameters of the infant itself. So here, are we asking ourselves, are we allowing this rib cage, this is a very old slide, are we allowing this rib cage, especially after it's had 2 puncture wounds, the kind of mobility it needs through its cervical spine and upper extremities, and even keeping a loose diaper and allowing the lower extremities to be flexed? There's always something you can be doing for the respiratory system through positioning. This is a baby that, if you look in Varese Book, it is an infant who is a 25-weeker who is normal at full term. This baby was built incorrectly. I blame the people who built this baby. I never, ever, ever blame the baby. So that's kind of something I've been looking at for years. This infant is stuck everywhere. Where? Pick your spot. And the price for a system actively maintained in a situation of better stability and shorter time constants is obviously a higher work of breathing. That's a pulmonary statement. Several intrinsic and neural mechanisms can effectively reduce the value of passive compliance and therefore reduce the operative time constant of the respiratory system. What this means is, when this infant was born, it was born with a very floppy, highly compliant chest, which leads to death in babies. So what we do is we put them in a certain sniff position. We overinflate their lungs because it keeps their positive airway pressures open and they don't die from pulmonary hemorrhages or atelectasis or lung collapse. We're forced to do that, but at some point, as this baby is growing, somebody has to be monitoring the compliance here and seeing it's now time for this baby to begin moving. And one of the things we look at, and it's just a simple slide from the Anatomy Chains book, is looking at how anatomy chains are set up from the cranium all the way down through the cervical spine, through the pharynx, through the hyoid, all these interlocking rib cage movements, thoracics, diaphragm, and muscles. So we already know that babies that are orally intubated look different than babies that are nasally intubated, and maybe we can talk about that at one time. But again, we're not talking about these cranial influences today. We're talking about these rib cage and subdiaphragm things. But we know that if you put your head back, for those of you who haven't tried, if you tip your head back and you look at the ceiling, as I was told, preterm infants love lights, originally in 1977, you'll see if you try to take a breath with your head in extension, you can't do it. And we're not going to analyze that because that's a cranial end, and we're going to look at just the diaphragm today. But everything is altered when the head is in extension. When a system is stressed, it adapts by ultimately changing the shape to assist at all levels with the balance of flow of resources and energy first, even if it's incorrect. If an infant is placed in a stress situation where rigid, incorrect, or ineffective compensatory movements are selected or dictated by us, then maladaptation in all areas of life's processes will occur. Please wait till about almost the last slide, and I will show you how this works, but we will talk about this. And you begin to set up negative somatic synergies. There you go. This baby cannot change its posture or position, cannot respire, cannot do anything it needs to do. So what are we going to look at? We're going to look at this so-called zone of apposition today. It's an old term used by Beckerman in many of his books, and Laughlin. So it looks at this part of the infant's body and what's going on there. If the rib cage is relatively stiff, and that's what happens in premature birth, due to either mechanical properties of the rib cage itself or contraction of the intercostal muscles, the diaphragm will have an expanding influence on the rib cage. Keep in mind, I'll mention this. It's not getting air into the preterm infant after a while. It's the ability for the rib cage to close and become smaller in flexion that dictates the ability to blow off CO2. And as soon as I said the word CO2, everyone who deals with a chronic lung disease baby, or as I call it, bronchopulmonary dysplasia, or any framework of that, knows that it's not the amount of air going in, it's the amount of CO2 being blown off, and we'll show you what happens. So when the diaphragm, the contraction of the crural diaphragm increases abdominal pressure, because the abdominal contents lie adjacent to the lower rib cage, like you didn't know that. Increments in the abdominal pressure may expand the lower rib cage. So what we have is between gravity, poor positioning, and actually the way the diaphragm functions in the infant, it keeps expanding into and towards hyperinflation. And the appositional component of the diaphragm's action on the rib cage actually assists with that. Now that's great if you're a full-term baby, but when you're a preterm baby, it doesn't give you any other options. So here's one of my diagrams of the diaphragm. Please, if any of you have any graphic abilities, take pity on me. And when we meet at these conferences, I look so forward to meeting people at NAMT and NOMAS and all these other national conferences, and we can have fun. We can have a glass of wine and draw pictures, whatever. But this is a lateral view of a flexed thoracic spine with the tensegrity structures. When you look at this diaphragm, it goes from that xiphoid anteriorly, wraps all the way down and goes all the way down to L2 on the left and L3 on the right. Now, those of you who orally intubate infants and begin to have torticollis, when I say torticollis is not a neck problem, it's tortisoma, it's a body problem. If a child's cervical spine is rotated, their diaphragm is rotated, and in fact, their diaphragm is already built to be asymmetrical for a lot of reasons, which we won't go into today. So the action of the ribcage muscles depend on the relative orientation of the fibers and their axis of rotation. Here's what we have. This is how I first saw babies. In many places, this is called the sniff position, and it's done to hyperexpand the lungs. It's done to allow the most positive pressure to go into an infant's lungs to keep them from collapsing. Thereby, they survive. But we need to have physicians and nurses understand this carries a biotensegrity legacy to it. And when that poor feeding therapist comes in at 32 or 33 or 34 weeks, if we haven't taken care of this posture during that period of time, their lives are going to be a hell, and the baby's lives and the mother's lives are going to be just as problematic. So we need to do what we have to do to maintain and respect chest compliance. But as soon as we begin to say, well, this baby is stabilized or beginning to stabilize, how are we going to help this infant breathe better? Well, this is what happens. That's you see what happens. The spine goes into extension. The diaphragm becomes stretched. It actually begins to be shortened at the top and actually elongates on the sides. And this baby now is really having problems both inspiring and especially expiring. And from the front, this is an infant thoracic cage. This is an adult thoracic cage. Everything we do for an infant tends to expand and flatten this diaphragmatic structure out. And when the flatter this diaphragm becomes in the horizontal plane, the less able it is to inspire and assist with expiration. And here you see it. These are some really nice pictures, but I want to show you this. This is there are 4 slides here that I think really make the point of the entire webinar. You can see here that if we keep this chest and rib cage in inhalation, it can't stretch out and expand and thereby allow exhalation to occur. It's like a circus tent. Here the tent is pulled taut. Here the tent is actually flowing up with the wind. And we see that the lungs actually change their shape, but, oops, I'm so sorry. In adults, the actual shape and angle of the alveoli will change as inhalation changes. The angle narrows to allow deeper draws into as we know, the basilar lobes where we breathe, and babies especially breathe down here. And then as we expire and follow this expanding tent, our alveoli have to have enough flexibility to allow this air to be blown off and the CO2 to be blown off. So when we position an infant, we're not only changing their rib cages, we're reaching down deep into the actual shapes of their bronchial tree and allowing them the flexibility they need to go along with their thoracic rib cage to inspire and expire. That's what adequate, good positioning and alignment allows. And as if that wasn't enough, these lungs actually go through a rotative compression and then are pumped, filled and pumped. Now, when you have bronchopulmonary dysplasia, the old term when I grew up was it was a wet lung. And what do we know about lungs? We know that they don't have their own lymphatics, that it is only through the motion of the lung tissue itself that adequate compression through inspiration and expiration actually pumps excess fluid out of the lung as well as CO2. So what am I saying here? I'm saying that adequate positioning, adequate flexion, paying attention to the abilities of this diaphragm and system to work as a whole is going to lead to better physiological control, first and foremost. So the distinctive shape allows or restricts compliance. And if you need to look at compliance and deformation abilities of the infant pediatric chest wall. This in turn causes adaptation by the respiratory controller, the neural controller, to maintain optimal respiratory functions. So we can see that this baby is having problems. You can almost see those alveoli stuck down at a lower angle or a wider angle, depending on which way you want to look at it. And this baby is stuck from the inside out. If we can control and use our handle of adequate positioning and alignment and posture pre, during, and post-feeding, we're going to have this system working at a much better clip, and therefore the systems above and below will be drawn into it. And here you see that this is just showing you what intercostal muscles and rectus abdominis have to be able to help close or go on and off, and especially those of you who've heard me speak about these transverse thoracic muscles. I think these are part of the neurocontrollers that actually tell babies when their chests are inflated or underinflated or overinflated, and they come offline very quickly in a baby like this. So. And here you see all this. You know, just to mention to people, you cannot have great or good or adequate thoracic expansion and contraction without paying attention to the alignment of the upper extremities on the rib cage. And here you see just a small part. And you know, we've all been saying this for years. So here's another picture of that same thing going over the rotation of the lung, the ability for the lung to rotate and help drive the chest wall. The chest wall moves away from the lung and then moves towards the lung, and this lung has to be flexible enough. I will just tell you that I have actually put my hands on autopsies. Some of my patients have gone to autopsy with severe BPD, and I've actually felt what their lungs feel like, and they feel like thin styrofoam. So this problem begins from the inside out and from the bottom up. And here, for those of you who are looking, when we talk about torsions and torticollis, this is an asymmetrical diaphragm, an asymmetrical system here. And all it needs is a tweak or a turn at the top, or a penetration from a chest tube, or poor positioning or malpositioning, to have everything from back musculatures. Look at this tent arrangement here. Look at how it's pinned down all the way around. And if you're interested, we will do some webinars on the nature of the diaphragm itself and what's different about the infants versus the adults. So it's really not enough to believe what you see. You must also understand what you see. So here's that side view again. Here's that flexed basketball of the abdominal contents sitting under this. And what do? But we place a diaper, this big green thing here. And that diaper, when it's tight, people always say to me, well, I want something to do with Monday morning as soon as I go back and see my kids, John. And I say to them, if you have babies with tight diapers, you have changed everything we talked about for the last how many slides. So keep that in mind. If you loosen diapers, the single best thing you can do is loosen diapers. Now, nurses are fastidious, and when babies are very, very ill, you have to have tight diapers because you can't have accidents and then they leak out and then you have to disturb the infant from their healing holistic sleep pattern. But you'll see, you can hear in the nursery when a mother puts on that diaper and you hear that snap, snap, and you know that kid is walking around with something that is inhibiting correct diaphragmatic movement through this zone of apposition of abdominal contents being compressed. So the best thing you can do, and watch it, undo the diaper, let the baby sit where it is, just relax it, do it very slow, don't disturb it. Just undo it, make it loose, and now you'll start to see respiratory rate changes for the better, pulmonary abilities, diaphragmatic movements go up. The baby may even sigh and say, thanks a lot, that was great. So, and if not, something simple. Tonight, go out for a big meal, take your belt and tighten it very tightly. And then tomorrow all day, wear your belt very tight. You will experience respiratory, abdominal, and elimination problems to the same thing. So first thing we can do right away, get people to work with tight diapers, loose diapers. So what is this all about, John? Well, we as therapists have to begin not to say, call me when the baby's ready to feed. We know so much. Nurses and physicians are looking to tip the scale in these babies' favors. We need to be involved early. And one of the things I'm saying is this ventilator-induced lung injury, this is page 158 in Bankalaria's book, discusses two things: volume trauma, atelectotrauma, and Barrow trauma. And those of you who have seen babies with severe chronic lung disease, we had 2 infants in my NICU in the 70s that lived in the intensive care unit till they were 5 years old. They could not go home. They could not be transferred. There weren't even places for them to go in the late 70s. So they lived in the intensive care unit. And I saw both of those babies' lungs at autopsy, and I can tell you that they had all 3 of these things. So volume trauma consists of damage caused by overdistension. Well, if a baby's positioned incorrectly and their rib cage is hyperinflated beyond the point of where they need it, are you helping change the amount of volume trauma by looking at proper positioning for the rib cage? The answer is yes. Atelectotrauma is a result of recruitment and collapse caused by level end expiratory pressures lower than the low inflection point of the pressure volume curve. I actually have an idea of what that is, or the regional presence of areas of atelectasis in disease-associated areas with lung disease. When we have babies positioned too much on one side and we overinflate lungs, we ask for atelectotrauma. Babies need a individualized, supported, this is one of the reasons why when we do skin to skin, I believe that you'll see that these 3 things will decrease, because it actually allows the infant to breathe basally because of a number of things, and we can talk about the kinematics of skin to skin one time. And then Barrow trauma, any mechanical ventilation related insult that induces the release of lung cytokinins or inflammatory mediators. Remember, we talked about a rib cage that is able to move and able to close is going to be a better functional unit, not only with less inflammation, but also less cytokines because there's less damage, and an ability to protect itself in the inflammatory immunological area. This is what developmental intervention is. So use the problems you're seeing with your feeding babies and saying to people, I would have loved to have gotten this baby 2 weeks earlier. I would have loved to have been on the team and helped you position this infant and work with the mother when you get her on here. Changing the position of an upper extremity or lower extremity can reduce all of these things. We tend to think as therapists or even nurses or physicians that there's nothing we can do about this. But if it has to do with the shape or function of the rib cage, we can change it. So these 3 mechanisms you have to account for in developmental caregiving. Yes, we do, because remember, synactivity is physiology first, the center of the tornado. Preterm infants may not be developmentally prepared to protect their lungs from potential injuries. So how do we accomplish this? Anyone, and that's really for when we do live audiences, usually physicians have a million ideas, and it's great to do this, show these things with people who, even respiratory therapists, really have things. So this is the whole in a nutshell. I just want to show you, please look at the right-hand side of your screen. One is looking at inhalation, one is looking at exhalation. And it's looking at the abdomen in the zone of apposition here. One is very flaccid, the other one's tightening up. We didn't talk about how babies really truly expire, but that's a talk for another day. We see this rib cage tensing and relaxing, expanding and contracting. But in order for this to happen, even the pelvic floor, this diaphragm comes down and pushes the contents. This pelvic floor, if it's the legs are in extension, it keeps the pelvic floor tense, and doesn't allow it this relaxing ability to help this structure shrink and passively push from the bottom of the infant all the way up. Secondly, if we go to the left here, every single structure in that abdomen is changing shape and posture. And when you hold a muscular-coated tube in one position for too long, what happens to it? We know this from basic physiology. It begins to decrease its functional abilities. So how many of our babies have problems in either the ability to move fluid and start through here, or the neural control of what's happening here backing up into the stomach and backing down into this other group? So all of these structures in here are actually going through a rotation and a twist and a turn. And lastly, we talked about this. Here you see the ability, there are people, osteopaths, neurosurgeons, physicians, PTs, OTs, speech therapists, who truly believe that venous return and dural cerebral spinal return, fluid return, are a function of breathing because they are time. That's part of their central pattern generator. So by changing the postures and positions here and allowing fluid to flow freely below, we actually change the ability for this skull to adapt and be deformed by intubations and CPAP and nasal prong CPAP and flow, nasal high flow cannulas, that this cranium is protected from the inside out. So when you begin to look at really how we have to begin to look at this part of the infant, we need to become experts here so that it affects everything we do for this infant. And whether you have an infant who's had a tough delivery or a difficult delivery, this baby may have feeding problems. There are things already going into play that are telling us this baby's gone through a rotational trauma in its head, neck, jaw, and it's actually beginning to shape and function here, and is not quite happy at this new delivery. And here's a baby, as you can see, this baby's like, you're going to feed me? I'm awake, but my head's an extension. I'm practically got this Vulcan death grip on the back of the ear, pushing the jaw forward or pulling the jaw up, whatever. And this mouth, I have a pore seal here, and I'm really, nobody's paying attention. It looks good, but it's not. How about this infant? This infant is telling you, well, I'm sidelined, but I'm also side bent. My alignment, and this is what therapists really understand and bring to a nursery, is the concepts of alignment in space and allowing this aerodigestive oral motor system to function at its best. And maybe this baby was feeding best this way, but you can see that this baby is not. Its behavioral component, the outside of the tornado, its attentional and state system, is telling you this is not a great deal. And as Dr. Stanford pointed out, and I did not thank Sandy Aubuchon and Dr. Mary Stanford and Steve for helping me put this together and giving me the opportunity to do this, so I'd like to do that now. So you can see here's something else. Now here you are. Here's your blank slate. Right here. Begin to intervene. This is a baby who isn't feeding yet, but yet how are we going to change the shape and the function of this rib cage and this zone of apposition and getting this head and neck and jaw to really be able to come around and be in alignment. And here you see both people. We talked about ergonomics. You see both therapist and infant are in good alignment. Things seem to be working. So you know all these things. You see it. We all see it. And I look forward to the comments we're going to have. So a lot of things go on from here up and down. And I think we have to, as feeding therapists, realize it's not just, this is the central pattern generator. This is the thing by which all of our sucking and swallowing and breathing is timed and built on. And if we don't pay attention to being more knowledgeable and more direct and more involved in this part of the infant's body, we're just continuing to see problems that poor feeding therapists have to deal with. You know, sometimes the messenger is shot. When the infant isn't feeding right, it's your fault, when in essence, it's what's happened for the 2 or 3 months before. Now, this is just a basic kind of heads up. Let's look at some things we need to do. So if there are comments and questions, we will wind up taking them very soon. We cannot solve the problems by using the same kind of thinking when we created them. And we are creating problems. We need to stop creating them, and we need to listen to the people who know what's going on. It's very scary to realize that developmental interventions can actually help with morbidity and maybe even mortality rates. And this we looked at when we worked at all the hospitals I've worked at. So it is a scary place to be put in. I want people to be in there earlier. I want them to be able to come together as a group when we get together and say, okay, how do we raise our game? How do we learn more about this respiratory pulmonary system and how it interlocks and interdigitates with that oral motor system? It's all about our intentions and our compassion and our abilities that we put into practice each and every day, which you have been doing and you will continue to do. So when you look at an infant, think of wisdom consists of the anticipation of consequences. What's happening with this infant right now that you as a feeding therapist have to look at as a consequence and seeing if we can remove it early and then remediate it afterwards?